So you have bloating, and you already tried cutting out gluten, drinking more water, taking probiotics, eating slower. And your stomach is still swelling up every afternoon like you are 6 months pregnant. I want you to know something. The problem probably isn't your diet, and it isn't your discipline, and it certainly is not in your head. What I see in clinic every single week is that most people with chronic bloating have already done the obvious things. They've cut out dairy, they've tried the elimination diets, they've spent money on probiotics that didn't work, and they're sitting across from me frustrated, a little embarrassed, wondering if their GI tract is just broken. You are not broken. What's happening is that the 5 or 6 most common causes of stubborn bloating almost never get picked up in a standard 10-minute primary care appointment. Not because anyone's doing a bad job, but because these diagnoses require specific tests, specific questions, and the specific training that most doctors outside of gastroenterology just don't use day to day. Hi, I'm Dr. Matthew Glover, and I'm a clinical gastroenterologist out in Las Vegas, Nevada. And after personally performing over 10,000 colonoscopies, endoscopies, and motility studies on thousands of patients, I've noticed the same pattern come through my door again and again. Someone has been bloated for months to years. They've been told it's IBS, they've been told to eat more fiber, but nobody's actually gone looking for the root cause. A couple weeks ago, I put out a video called Why You're Bloated, 5 simple fixes that actually help. A lot of you watched it. Many of my patients said those fixes worked, but there was also a significant proportion who said the video did not go far enough. And that told me exactly what the next video needed to be about. So today I want to walk you through the 5 hidden causes of bloating that I see missed constantly. Causes that I test for in my GI patients in clinic, but that almost never come up on the first visit to a family doctor. Signs that your bloating isn't about what you ate yesterday. It's something specific happening in your gut that needs a different approach. And if you stick around till cause number 5, I'll explain the one I see misdiagnosed more than any other. It has nothing to do with what you eat. Most people have never heard of it, and fixing it can make decades of bloating vanish in weeks. Before we get into it, do me a quick favor and check that you're subscribed to this channel. Only a small fraction of the people watching these videos are actually subscribed. Your subscription helps support this channel so that I can find the time to keep making these videos, and it helps others on YouTube find these videos as well. If even one person watching this finally gets an answer to years of being bloated, then it's all worth it. So thank you, and let's get right into the content. The first cause, and probably the most common one I diagnose in patients who have failed every diet they've tried, is something called SIBO, small intestinal bacterial overgrowth. Here's a quick anatomy lesson. Most of the bacteria in your gut are supposed to live in your colon, your large intestine. Your small intestine, which is where you actually digest and absorb food, is relatively quiet and sterile, a low bacteria zone. When bacteria migrate up from the colon into the small intestine and start setting up shop where they don't belong, you get SIBO. And the reason this causes bloating is rather straightforward. When you eat carbohydrates, even healthy ones like onions, garlic, apples, beans, those bacteria in the wrong place get to them before you do. They ferment those carbohydrates. Fermentation produces gas, and we're talking hydrogen, methane, and sometimes hydrogen sulfide. And because this is happening in your small intestine instead of your colon, the gas has nowhere to go. It distends your belly, often within an hour of eating, and it can stay there the rest of the day. The telltale pattern I look for is bloating that gets dramatically worse as the day goes on. You wake up with a flat stomach, but by dinner, you look 6 months pregnant. You burp a lot, you may have brain fog, you have alternating diarrhea and constipation. That is the SIBO fingerprint. The official diagnosis is a breath test, a lactulose or glucose breath test. However, I want to be honest with you. In clinical practice, I do not use these breath tests. The The reason is that all these breath tests have both poor sensitivity and specificity, meaning that if the test is positive, we are not actually sure it's really positive. And if it's negative, the same applies. We're not sure that this is a true negative. Therefore, in my clinic, for my patients, I typically go straight to an empiric round of antibiotics and assess clinical response. The specific antibiotic most often used is rifaximin, sometimes paired with a prokinetic to keep things moving and prevent relapse. Augmentin can be used as second line. Antibiotics are not a forever treatment, but for a lot of people, the bloating they've had for 5 to 10 years resolves within 2 to 4 weeks. The reason SIBO gets missed so often is that a regular stool test won't find it. A colonoscopy won't find it. You have to specifically know about this diagnosis and ask your doctor for SIBO to be considered. The second cause is carbohydrate malabsorption, and I don't just mean lactose. Most people think that if they don't have an issue with milk, they're fine, but there's actually more to it. There are at least 4 common sugars that a significant proportion of the population cannot fully digest. Lactose from dairy, fructose from fruit, honey, and high fructose corn syrup, sorbitol and mannitol from sugar-free gum, mints, and stone fruits like peaches and plums. And finally, sucrose, which is a table sugar, and there's actually a congenital sucrase isomaltase deficiency that's more common than people realize, and it often shows up later in life in adults. And here's what happens when you eat a sugar that you can't absorb properly. The sugar sits in your small intestine, and because sugar is osmotically active, it pulls water into the gut. That water gives you loose stools or diarrhea. Then it moves down into the colon, where your bacteria ferment it, again producing gas. So you get a double hit: water-driven diarrhea or urgency and gas-driven bloating. What makes this tricky to figure out on your own is that the foods are often the ones we think of as healthy. We're talking apples, pears, mangoes, honey in your tea, sugar-free protein bars full of sorbitol, a big handful of dried fruit as a snack. You're doing everything right by conventional wisdom and feeling ever worse. In clinic, we can test for fructose malabsorption and lactose intolerance directly with breath tests. But we have already spoken about the limitations of these breath tests in the previous section. A lot of the time, the best diagnostic tool is a structured low FODMAP elimination diet, done properly, meaning 3 to 6 weeks of strict elimination and then a systematic reintroduction, one category at a time, to find your specific triggers. Done right, this identifies the exact sugars your gut can't handle. You don't have to give up all the FODMAP foods forever. Just learn which ones are your specific triggers. If you've tried cutting out gluten and it didn't help, this is usually where I'd look next. Number 3 is slow gastric emptying, also called gastroparesis. This one has gotten exponentially more common in the last few years, and I'll explain why in a second. Your stomach is supposed to empty most of a meal into your small intestine within about 2 to 4 hours. When the muscles of the stomach don't contract properly because of nerve damage, medication side effects, diabetes, or other causes, food sits in the stomach much longer than it should, sometimes up to 6, 8, even 10 hours. When food sits in the stomach, 2 things happen. First, your stomach stretches. That's the pressure and fullness that patients describe as bloating in the upper abdomen, right below the ribs. Second, bacteria start to ferment that retained food before it even leaves the stomach. So you end up getting fullness, nausea, burping, early satiety, meaning you feel stuffed after just a few bites, and bloating that sits high rather than low. Now here's the part I want you to pay attention to. These new GLP-1 medications, such as Ozempic, Wegovy, Mounjaro, Zepbound, work partially by slowing gastric emptying. That's a feature, not a bug, because it's how they make you feel full on less food. But a real side effect of those medications is persistent bloating, nausea, upper abdominal fullness, and this can linger for months. I'm diagnosing medication-related gastroparesis in my clinic more than I did 5 years ago, and it's almost always patients who started the GLP-1 and didn't connect the dots. If you want a more detailed explanation of what exactly these GLP-1 medications are doing inside your GI tract, you can check out my video on this very topic titled GLP-1s in Your Gut, the Unexpected GI Frontier. The other big culprits are uncontrolled type 2 diabetes, certain antidepressants, opiate pain medications, and sometimes a post-viral nerve issue that shows up after an infection. It is normal for gastric emptying to be impaired after such an infectious insult, such as food poisoning. And this can sometimes take weeks to months to fully resolve. We call this post-infectious irritable bowel syndrome. The test for gastroparesis is a gastric emptying study. You take a standardized meal with a tracer and watch how long it takes to leave your stomach. Treatment depends on the cause, but it often involves gastroparetic diet, meaning smaller meals, lower fat and fiber, a prokinetic medication, and if it's medication-induced, sometimes stopping or adjusting the drug that's causing it. Cause number 4 is one that almost never gets diagnosed outside of a GI clinic, and that's bile acid malabsorption. Your liver makes bile acids. They are deposited then into your small intestine to help you digest fat. Then, under normal conditions, about 95% of those bile acids get reabsorbed at the very end of your small intestine and recycled. When that reabsorption cycle breaks down because of past gallbladder removal, previous gut surgery, Crohn's disease, or inflammation, those bile acids spill into the colon where they don't belong. Bile acids in the colon are irritating. They pull water in, they speed up transit, they disturb the gut microbiome, and the result is bloating, urgency, cramping, and a specific kind of diarrhea that often hits about 30 minutes after eating, especially after fatty meals. Patients will tell me they can't eat anything with fat in it without running to the bathroom right after. This one is wildly underdiagnosed. Studies suggest that up to a third of patients carrying a diagnosis of IBS with diarrhea actually have bile acid malabsorption, not IBS. They've been told for years that they just have a sensitive gut, when in fact, there's a specific treatable cause. In my patients, I typically make this diagnosis clinically, meaning they have worsening diarrhea in the weeks to months following a cholecystectomy, meaning gallbladder removal. And we typically start with a therapeutic trial of a bile acid binder, a medication called cholestyramine. If the symptoms resolve on a bile acid binder, that's essentially diagnostic. And those medications are generic, inexpensive, and work quickly when this is the right diagnosis. If you've had your gallbladder out and you've never been the same since, this is probably your answer. Now we're at number 5, and this is the one I promised would surprise you. It surprised me when I first started diagnosing it in clinical practice years ago, and it's probably the most frequently missed cause of chronic bloating in women especially, although it absolutely happens in men as well. And I'm referring to pelvic floor dysfunction, sometimes called dyssynergic defecation. I want to start this section with a quick clinical anecdote. Several months ago, I had a 55-year-old female come to me for a third opinion at my clinic out here in Las Vegas. She was absolutely miserable. Her chief complaint was bloating and a sense of incomplete evacuation with bowel movements. She never felt fully empty, and the bloating was destroying her life. She had already seen 2 gastroenterologists and had had every test under the sun performed. Upper endoscopy, colonoscopy, stool studies, labs, imaging, and was told nothing could be done. She exercised daily, ate a healthy diet with plenty of fiber, all to no avail. As I spoke with her, it became obvious that a diagnosis of pelvic floor dysfunction had never been considered. And we ordered the appropriate workup. Sure enough, This testing confirmed dyssynergic defecation, and we sent her for pelvic floor physical therapy. I saw her back in clinic last week. The improvement after physical therapy was absolutely life-changing. Years of bloating and discomfort resolved, and it reminded me of two things. Number one, the ability to offer relief to my patients by diagnosing underappreciated pathology is the very reason I went to medical school, why medicine is so rewarding, and that all the education in school was worth every minute. And number two, it emphasized yet again that pelvic floor dysfunction is one of the most under-recognized and underdiagnosed issues in all of gut health. Here's what pelvic floor dysfunction actually is. When you go to have a bowel movement, a specific group of muscles in your pelvic floor are supposed to relax, while the muscles in your rectum contract to push the stool out. Those two things need to happen in a coordinated fashion. In a significant percentage of people, that coordination is broken. The muscles that should relax actually tighten, and the muscles that should tighten actually relax. So stool sits in the rectum, gas gets trapped behind it, pressure builds up, and the bloating is constant because your colon cannot fully empty. What these patients describe to me is very specific, a sensation of incomplete evacuation even after what feels like a normal bowel movement, straining, sitting on the toilet for a long time, sometimes having to splint, to physically press on the abdomen or perineum to get the stool out. Bloating that's worse at the end of the day and does not respond to any dietary interventions, and often years of being told that they just need more fiber, which, if you have pelvic floor dysfunction, often makes things worse because you're piling more stool on top of a system that cannot clear itself. This is not a rare condition. Studies suggest up to 40% of people with chronic constipation have an element of pelvic floor dysfunction, and yet it almost never gets tested for in primary care, mostly because the testing, meaning anorectal manometry with balloon expulsion and MRI defecography, is rarely recognized and appreciated outside of gastroenterology clinics. Even most GI doctors do not recognize this condition. But here's the good news. Pelvic floor dysfunction responds beautifully to pelvic floor physical therapy, not regular PT, specifically trained pelvic floor therapy, often with biofeedback. I've had patients for 30 years of daily bloating become normal in 8 to 12 weeks of the right therapy. No medication, no dietary changes, no surgery. Just retraining the muscles that forgot how to coordinate. If you've been told you have IBS-C or chronic constipation and fiber isn't fixing it, please ask your doctor to consider pelvic floor dysfunction or find a gastroenterologist who does motility work. The vast majority of chronic bloating is not dangerous. It's uncomfortable, it's life-limiting, and it deserves to be taken seriously, but it's rarely caused by something sinister. That being said, there are specific features that move bloating from annoying to needs to be evaluated now. Here are the red flags I tell my patients to watch for. Unintentional weight loss. Not 10 pounds lost because you've been eating less, but weight that's dropping without you trying. Blood in the stool, either bright red or dark and tarry. Bloating that's brand new after age 50 and persistent. A family history of colon cancer or ovarian cancer. Fevers, night sweats, or fatigue that goes beyond simple tiredness. A sudden and dramatic change in bowel habits that doesn't resolve after a few weeks. Early satiety plus weight loss combined, or pain that wakes you up in the middle of the night. Any of those, in combination with bloating, needs a proper workup. We're talking about blood work, imaging where appropriate, and likely an endoscopy and or colonoscopy. Please don't sit on these symptoms. Ovarian cancer in particular can present with this exact pattern in women, and the earlier we can catch it, the more we can do about it. For everyone else, the path forward is the same. Start with the interventions and workup mentioned in this video. If you're still bloated after 3 to 4 weeks of honest effort, it's time to get evaluated properly, and specifically for the 6 things we just talked about in this video. So let's bring this all together. Bloating that survives a clean diet, more water, more fiber, probiotics, and eating slower isn't stubbornness. It's a signal. It usually means either SIBO, a specific carbohydrate malabsorption, slow gastric emptying, bile acid malabsorption, or pelvic floor dysfunction. And each of these has a real test and a real treatment. Most of my patients have been bloated to years before they walk into my clinic. And when we find the right answer, the turnaround is surprisingly fast. Weeks, not decades. You just have to go looking for the root cause. If you've been told it's IBS and left without a clear plan, that is not a diagnosis. That's a label, and you deserve better. I really hope this information was useful for you, and I'm doing my absolute best to put out high-yield content on a regular basis to improve your gut health. If you found this video valuable, consider giving it a like, sharing it with someone who you think could benefit from this information, and subscribe to the channel. It genuinely helps these videos reach more people who can benefit from this information and keeps you up to date with my latest videos. And stay tuned for my next video, IBS versus colon cancer, key differences, when to worry, and what a proper workup entails. Drop a comment telling me which of these 6 bloating causes you think might apply in your circumstance. Thank you so much for watching, and I'll see you in the next one.